Good evening, everyone. Welcome to the weekly head and neck webinar series from Mahavir Cancer Sansthan. Myself, Dr. Vinay Venkatramu, Senior Consultant from Head and Neck Surgical Oncology Department, and I will be moderating this. Today's topic is adjuvant therapy in oral cavity cancers. It is presented by Dr. Nirdhum Shikha from the Head and Neck Department. Today, we have Dr. Richa Chauhan as a session moderator. She is a senior radiation oncologist from Mahavir Cancer Sansthan. She is also representing Mahavir Cancer Sansthan in India Advisory Group for prestigious American Society of Clinical Oncology. Welcome, ma'am. It's a pleasure to have you here to moderate this session.
Thank you, Dr. Vinay. And first of all, thanks a lot for initiating this, educational forum, which will benefit all the residents and all the trainees. So today the topic is adjuvant therapy in oral cancer. I think all of us know that lip and oral cavity, that is a major burden for, all the oncologists in India. And surgery undoubtedly is the mainstay of treatment. But then because most of our patients, they come in a locally advanced stage, after surgery, we need to risk adapt the patient, whether they need adjuvant therapy or not. I think Dr. Shikha has done a wonderful job in preparing a lot of all the details we have. So we'll first, now I request Dr. Shikha to start her presentation, and then we can take up the questions or discuss whatever the participants would. Dr. Shikha? Dr. Shikha?
Thank you, ma'am. Thank you, ma'am.
Please start.
Good evening, one and all. I am Dr. Nirdhum Shikha, Senior Resident at Mahavir Cancer Sansthan. I'll be presenting my seminar on adjuvant therapy in oral cancer. I'll be covering under the following subheadings. Oral cavity squamous cell carcinoma represents a significant global health problem, with most patients presenting in advanced stages, which is up to 40 to 70%. Now, these patients present with multiple risk factors, which have got very high chance of recurrence. Thus, surgery followed by appropriate adjuvant treatment in these cases remains the standard of care. Now, we can divide this patients in three categories as per NCCN guidelines. The first is low risk, in which the patients are treated with surgery alone. Stage 1, stage 2 disease with no margin involvement and zero positive lymph nodes are considered under low risk category. In the intermediate risk, where the patient is with stage 3 and stage 4 disease, which did not have positive margins and extranodal extension, are intermediate risk patients, and they are recommended for adjuvant radiotherapy after surgical resection. High group patients, they are the patients who are with positive margins or extranodal extension. And in this group of patients, adjuvant chemotherapy along with radiotherapy is advised. Now, after we get a patient and after a proper workup, including biopsy, imaging, and distant metastasis workup, clinical staging of the patient is done. And if the disease is resectable, we plan and go ahead with surgery. This is the clinical staging of oral cavity tumors, where it is divided into T1, T2, T3, T4, and N0, N1, N2, and N3. Now, when it comes to T1 and T2 with N0, it is advisable and preferred to go ahead with surgery. And if in pathology there are no nodes or any adverse pathologic features, it is advised to follow up the patient. But in these patients, if there is a one positive node without any other pathologic feature, for adjuvant treatment, radiation is considered. Other than this, any other pathologic features like extranodal extension and positive margin. In extranodal extension, systemic therapy is advised along with radiation therapy. In positive margin, re-resection, if it is feasible, is considered. However, there are many studies which have showed that re-resection is not as good as when it is taken as a fresh margin. So in those cases, the disease-free survival and overall survival is not equivalent to those when it is taken in one section. And the other method, adjuvant treatment for this is systemic therapy and radiation therapy. Now, if there is any other risk features like nodal disease, nodal disease in level 4 or 5, perineural invasion, vascular invasion, lymphatic invasion, then in that case, clinical decision of RT or consideration for systemic therapy is done. Now coming to T3 and T4 disease. In case of T3, T4 disease, when there is no adverse pathologic features, radiation is considered as an adjuvant treatment. When there is adverse pathologic features like extranodal extension or positive margin, in extranodal extension, again, systemic therapy with radiation is advised, and in positive margin, re-resection if feasible, and systemic therapy with radiation as adjuvant is advised. And same with the risk features. Now, what is the principle of radiation therapy? It is preferred to be given at an interval between the resection and post-operative radiation treatment within 6 weeks or less than 6 weeks. If any of these patients have come under high risk with adverse pathologic features like a positive margin, in those cases 60 to 66 gray with 2 gray per fraction is advised from Monday to Friday in 6 to 6.5 weeks of time. In low to intermediate risk, sites of suspected subclinical spread where 44 to 50 gray is advised and 2 gray per fraction is given. It can be increased up to 54 to 63 gray, which can be given at 1.6 to 1.8 gray per fraction. Along with this, concurrent systemic therapy can be given. Now, what are the indications of concurrent chemotherapy? First is positive margin, second is pathological extranodal extension, and third is post-NACT. Now, in NACT, it was not added in the NCCN guidelines, but there was a study which was done by Chalker et al., where this was to be given because there will be possibility of persistent residual microscopic tumor island in which it has not shrunk non-concentrically from the induction chemotherapy. So to address these cases in post-NACT, concurrent chemoradiotherapy is advisable. Now, cisplatin. Cisplatin is the standard of choice for chemotherapy at present. The dose at which it is given is 100 milligram per meter square once every 3 weeks. This strategy has improved in loco-regional control, disease-free survival, and overall survival. However, there are acute and long-term toxicities which are associated with it, which includes mucositis, myelosuppression, ototoxicity, nephrotoxicity, etc. There was a study which was conducted by Noronha et al., where a weekly cisplatin at 30 milligram per meter square was advised. However, there was no significant improvement in the loco-regional control or TFS and overall survival was seen. There was another study which was done by Kiyota et al. It was found that cisplatin, when it was changed weekly to 40 milligram per meter square, had better results. Now, coming to the contraindications of cisplatin or to platinum, it is divided into absolute and relative. In absolute, it is if the patient has a ECOG of 3 or 4, renal dysfunction of 15 milliliter per minute. Grade 2 or higher organ dysfunction, including deafness, tinnitus, neurologic dysfunction, hypersensitivity to platinum, pregnancy and lactating women, patient with HIV/AIDS with CDC cell count less than 200 per ml. Now, in relative, one has to assess the risk to benefit ratio of cisplatin. The relative contraindications would be ECOG of 2, age more than 70 years, borderline organ dysfunction, calculated creatinine clearance of 50 to 60 ml per minute, various comorbidities, lack of social support, and if in case the patient has taken a cumulative platinum dose more than 200 milligram per meter square, if there is unintentional weight loss more than 20%, concurrent use of nephrotoxic drug. Now, there was one study which was conducted by Schutz et al. In 2019, and it was mentioned that we should not keep age as a criteria, because it should depend on the performance scale of the patient rather than going on the chronological age of the patient. Now, in what should be the alternative of cisplatin if in case it is a cisplatin ineligible patient? Carboplatin, though there is no benefit in disease-free survival, this is one alternative. Pembrolizumab, nivolumab. Nivolumab can be used in elderly patients. Another one is docetaxel. Now, post-operative concurrent radiotherapy and chemotherapy for high-risk SCC patients. This was a study which was conducted by Cooper et al. This is RTOG study, and in
यार बोले तो वो कुछ discussions रहते हैं.
And in this
अभी तो डिस्कशन करो बच्चे कैसे करने करके वो छोड़ के तुम.
I would request to switch off your mics, please. So I think there is some intervention in presentation.
Thank you, sir.
Mr. Dr. Sujit, please switch off your mic. Dr. Shikha, please continue.
Yes, sir. So this was a study which was conducted by Cooper et al. It is one of the landmark trials which was done in head and neck with for adjuvant treatment. For high-risk characteristics which was included in the studies were histologic evidence of invasion of 2 or more regional lymph nodes, if there was extracapsular extension of the nodal disease, or if there was a microscopically involved mucosal margin of resection. Now, all the patients were randomly allocated into 2 groups. One was radiotherapy alone, and second was concurrently with cisplatin. This study was conducted between 1995 to 2000, and a total of 459 patients were enrolled with a follow-up of 24 months. The median time was around 45 months. Now, the total number of patients in RT group was 210, out of which 62 patients were of oral cavity. And in the cisplatin and RT group, a total number of patients were 206, and oral cavity patients were 50, which was comparable. Now, when we see the local and regional recurrence, it was significant statistically, and it was seen to be more in the RT group. And again, the loco-regional control was more in the cisplatin and RT group. Distance metastasis was seen in the RT group alone. Adverse effects was seen to be more and almost double in cisplatin radiation group, which was very much statistically significant. Adverse effects was again statistically significant in the cisplatin radiotherapy arm. Now, the overall survival and the loco-regional control was significantly higher, and the time to progression was significantly longer in the concurrent combined group. But however, the adverse effects which was seen in the concurrent treatment group was more, and 4 patients had died as a result of directly to the treatment. 27 patients of them had grade 4 to grade 5 adverse effects compared to 7% which was seen in the radiotherapy group alone. Now, as that study was of median follow-up of 45 months, so this was the extension of the same study, which was for 10 years with a median follow-up survival of 9.4 years. Now, as we had seen that the local and the regional recurrence there was statistically significant with a p-value of 0.01. However, at the 10-year, the p-value was 0.1. Now, the recurrences again was higher in the RT group, which was 28.8. Disease-free survival and overall survival was more in cisplatin and radiation, arm, and overall survival was statistically significant. Cause-specific analysis again was higher in the cisplatin, which was 41. Late toxicity was almost double and was again seen in cisplatin and radiotherapy arm. However, the grade 3 and grade 4 late toxicity after 5 years was more in the RT group compared to the cisplatin, and it was more than double. Now, other than that, what they found was 2 or more if lymph nodes were involved, it did not get benefited from addition of cisplatin. However, the long-term benefit was seen with addition of concurrent cisplatin to the post-operative RT for loco-regional control, disease-free survival, and overall survival. Now, this is another landmark article for adjuvant treatment, which was by Bernier et al., URTC 22391. Now, the aim of the study was, does adjuvant chemoradiotherapy improves the progression-free survival, overall survival, local and regional control more than radiation alone? In this, the group of the patients were stage 3 and stage 4 head and neck cancer. The primary objective was cisplatin incremental relapse, acute and late adverse effect. The radiation given was 66 grade, 33 fractions. Cisplatin was given 3 weekly at first, 22nd and 43rd day, 100 milligram per meter square, and 334 patients were enrolled in this, and with 167 in each group. The median follow-up was 60 months, and when we look at the 5 years data, the treatment failure was seen to be higher in the RT alone group, which was again statistically significant. 5-year progression-free survival was more in chemoradio arm, which was 47%, statistically significant. Metastasis was higher in RT group, which was not statistically significant, and overall survival was ahead of RT group by 13% with a statistical significant value. Now, when we combine everything, the combined treatment with cisplatin had better progression-free survival and loco-regional control and overall survival. This is another study, RTOG trial 0234, which is done by Harari et al. It was a phase 2 randomized study where cetuximab was used along with cisplatin, and cetuximab was used with docetaxel. The total number of patients enrolled in this study was 203, and 95 of them had oral cancer. Now, when we look at the toxicities, the toxicity was more in the cisplatin group compared to the docetaxel group, except for the skin rash, and also the disease-free survival and overall survival was much more in the docetaxel arm than the cisplatin arm. There was another a study which proved docetaxel, when it is added to the radiation in patients who were cisplatin eligible, they had prolonged disease-free survival and overall survival. So it can be used as an alternative to cisplatin in cases where a patient cannot take cisplatin. Now, this was another randomized study which was done by Adjuvant et al. The total number of patients were 72 of stage 3 and stage 4 head and neck squamous cell carcinoma, out of which 25 were oral cancers. Now, the arms were, first arm was radiation alone, and in the second arm it was carboplatin with radiation. The carboplatin was given at a dose of 100 milligram per meter square weekly. for 6 weeks. When we compared both the groups, the disease-free survival and the overall survival, though was higher in the carboplatin arm, but the study was terminated early because of the poor accuracy. This is a very recent trial, which is a phase 3 randomized trial by Sarbani et al. Now, the aim of this study was to identify high-risk oral cavity cancer patients and to ascertain the optimal intensification modality in these patients. The inclusion criteria was histologically proven, previously untreated patients, non-metastatic, resected oral cavity squamous cell carcinoma. Age was between 18 to 65 years of age, with a performance scale from 60 to 100. And the patients who were included in this study were stage 3 and stage 4. The exclusion criteria was if the patient had any prior cancer, synchronous head and neck primaries, macroscopic residuals, and severe comorbidities. Patients who were included were having one or more of the following adverse pathological features. There was extracapsular extension, involvement of 2 regional lymph nodes, involved margin, extensive soft tissue or skin infiltration requiring major reconstruction, perineural invasion, and lymphovascular embolization. Now again, it was divided into 3 arms. The first arm was radiation arm alone. The second arm was concurrent chemoradiation, where cisplatin was given with radiation. The radiation was given 5 per week, and total of 6 weeks radiation was given. The third is concurrent weekly cisplatin and accelerated RT arm, where cisplatin was given and RT was given in accelerated 6 times per week for 5 weeks. Now, if you see the patient allocation, in arm A it was 299, arm B it was 301, and arm C it was 300. It was a 10-year study from 2005 to 2013. Now, if we see the loco-regional control, though it was higher in arm C, that was 65.7, it was not statistically significant. The DFS and overall survival was more in arm B, and again, it was not significant. There was a subset analysis which is done for T3, T4, N2, and N3, and patients with extracapsular extension. Again, the allocation of patients were very much comparable. In arm A, it was 103, arm B, it was 102, and arm C, it was 106. Local regional control was again similarly higher in arm C, and DFS and overall survival was higher in arm B. And P was not significant in any of these 3. Now, in the EC extracapsular extension positivity, there was lack of benefit. It could be because of overall heterogeneity in its presentation and behavior. Although both the intensification methods were biologically superior to the adjuvant RT alone, the most important was in cases of nodal positivity. There was a national cancer database analysis which is done, and which showed that in cases of 5 to 6 nodal positivity, it was better to give concurrent chemoradiation over RT for better survival. Now, a similar subset analysis was done in this, where again patients with 5 to 6 nodal positivity or more were included, and in arm A it was 43 patients, arm B it was 49 patients, and arm C it was 49 patients again. Again, comparable number of patients. The loco-regional control again was seen to be higher in concurrent chemoradiotherapy and concurrent weekly cisplatin and accelerated RT than the RT arm, though it was statistically not significant. When we see the patterns of failure in all the 3 arms, it was nearly similar, but it was not statistically significant. When we see the distance metastasis, it was found to be higher in RT arm. It is a very good trial and one of the latest phase 3 randomized trial. However, there were few caveats, which was poor prognostic factors like mandibular erosion and depth of invasion was not seen. Only sites which were included in the study was gingiva, buccal, tongue, and floor of mouth. Now, this was a study which was done for early stage oral cavity squamous cell carcinoma. As we know that the adjuvant treatment is not required in cases of early stage oral cavity squamous cell carcinoma until unless there are some adverse features associated with it. So there was this study which was done retrospectively in 1,257 patients, where 33 patients presented with positive margin, close margin was seen in 205, and remaining 1,019 patients had clear margin. Again, the overall survival, when it was compared amongst them, in patients who have stage 1 and stage 2, and if they have positive or close margin, for better survival, adjuvant treatment is advised. Coming to the depth of invasion is also an independent prognostic factor. Now, what is depth of invasion? If we see in this photograph, the horizontal line, the horizon is established at the level of the basement membrane of the normal mucosa. And if we drop a plumb line from there till the disease, that is our depth of invasion. Now, this is one article which has compared whether the tumor diameter or depth of invasion indicates the need for adjuvant RT. So it was a retrospective study which was done, and all the patients who were previously staged according to the tumor diameter were downstage or upstaged as per the DOI. In this study, adjuvant RT was given for PT4A, more than 2 lymph node metastasis, presence of PNI, perineural spread, lymphovascular invasion, closed resection margin, poorly differentiation. Now, chemoradiation was given for extranodal extension, soft tissue metastasis, a radical resection. So, total number of patients which were included in the study were 133, and RT was given in 71 patients. Chemoradiotherapy was given in 23 patients, and 39 amongst them did not receive any adjuvant treatment. The follow-up was of 24 months median. Now, they found that the group with adjuvant treatment showed higher overall oral survival than the group without adjuvant RT. That was more strictly seen in T2 and T3 group. In T1, if we see, the patients who had been given adjuvant radiotherapy in the DOI had comparatively lesser survival compared to the patients not given adjuvant RT. The only probable reason to explain this will be the adverse effects of the adjuvant treatment. If we see in the T2 group, it was a 10% increase of the survival compared to with the patient who were not given adjuvant RT. Even in T3, 15% of increased survival was seen. Now, the disadvantage of this study was it was a retrospective study and less number of patients, which is only 133 were included in the study. Now, as the patients were upstaged and downstaged, we can correlate with this with the Bill Rogers phenomenon, which was described by Feinstein et al., who had quoted it as Will Rogers' joke. When the Okies moved to California, the IQ of both the states went up. So as the migration of the patients from T3 to T2 and upstaging happened, the overall survival of both the T2 and T3 had improved. Now the next independent prognostic factor was perineural invasion. Perineural is generally accepted when at least 33% of the nerve circumference is surrounded by the tumor cells. So in this study, they have asked what to do if PNI is the only adverse histological factor. As per NCCN, it is advised to use clinical judgment. So in this study, a retrospective review of 1524 patients was done, and out of which 310 patients had PNI positive. So when the overall survival between both the groups were noted, it was almost double in patients without PNI at 3 years with a statistical significant value. Even the disease-free survival was significant. Now when ECS was extracapsular spread was seen, it was seen in 494 patients, out of which 151 patients also presented with PNI. But when we looked at the overall survival in patient who had ECS without PNI had better survival than compared with the patient who had PNI and extracapsular spread both present. So when we see PNI, it is more commonly seen in tongue cancers than we see in buccal mucosa cancer with about 28.3 in tongue cancer and 16% as it was seen in this study, which was statistically significant. The second thing was poorly differentiated tumors, where a single or small group of tumor cells can gain easy access to the perineural spread than the cohesive sheet of cells. The third is in cases of early T1 and T2 tumors, it was less, which was 17.3 compared to advanced T3 or T4 disease, where it was up to 24.7, which is again statistically significant. The last one is the nodal metastasis in patients with PNI. It was seen to be around 64.2 than in patients without PNI, where it was 38.9 with a significant p-value. So PNI is more commonly seen in tongue cancer, poorly differentiated tumors, in advanced T-stage nodal metastasis. However, PNI is an independent predictor for overall survival and disease-free survival, as it is seen here. So what we should do is we should go ahead with aggressive treatment of the primary. Along with that, we should advise adjuvant radiation and also management of neck lymph nodes. So this is another controversy, which is like if there is a single node which is positive, should we give adjuvant therapy or not? So this was a study which was conducted between 2004 to 2015, and 243 patients were operated with curative intent. Pathologically, there was a single positive node, out of which 168 patients received adjuvant therapy, 78 of them received adjuvant radiation alone, and 90 patients received adjuvant concurrent chemoradiotherapy. The median follow-up time for all these patients was 4.6 years. Now what they found was, with the addition of adjuvant therapy, there was no higher overall survival. But actually what was noted in the study, with perineural invasion positive patients had decreased overall survival compared to patients who had who had no PNI, which was statistically significant in overall survival, locoregional free survival, recurrence free survival, and also in the distant metastasis. So again, it was not the node which was the independent prognostic factor. It was the PNI which was told to be an independent prognostic factor in the study. So treatment intensification to adjuvant concurrent chemoradiotherapy also did not improve the outcome. of overall survival, locoregional recurrence-free survival, and distance metastasis-free survival. Now, there are two groups of people and two school of thoughts where one advocate for adjuvant radiotherapy in single positive node, and there is another school which says not to advise adjuvant RT. So in the first group, it was Shime et al., which was a sheer database analysis in which 1539 PN1 patients were seen, and they were given radiation, and they had significantly improved survival with a significant p-value. Another study again was done by Cow et al., where 2,451 patients were given significant. There was another study by Chen et al., where 1,467 patients were given adjuvant RT, and they had better survival. Coming to the group which do not advise adjuvant RT in a single node positive was given by American Society of Clinical Oncology Clinical Practice Guideline 2019. The second was Jekyll et al., where he found the 10% rate of isolated nodal failure was seen without adjuvant treatment with no survival benefit. And similarly, in the same study here, our isolated neck recurrence was found to be 9.3% in patients who did not receive adjuvant therapy with no benefit in survival. Now, in cases if there is a very heavy nodal burden, which becomes a very high risk factor. So this was a National Cancer Database analysis, which was done from 2004 to 2014, in which two randomized studies were taken, RTOG 9501 and EORTC 22931. Total number of patients were 7,144, and concurrent chemoradiation was given in 2,465 patients, and RT alone was given in 4,679 patients. The median follow-up was about 47 months. So as we can see in this forest plot, the number of positive lymph nodes, as they increase, the advantage, the survival is better with the chemo RT than RT alone. So if a patient has a pathological lymph node positive more than 3 to 5 or more than 6, it is advisable to give chemo RT than RT alone. Now, again, patients with higher number of positive lymph nodes derive more relative and absolute improvement in overall survival from the post-operative chemoradiation therapy with 6 or more positive lymph nodes. Coming to the oral squamous cell carcinoma risk stratification with nomograms, is divided into 3 groups. Low risk group, in bivariate analysis, PNI and pathological node stage were found to be the negative prognostic factors, whereas in the multivariate Cox regulation analysis, it was only PNI. In the intermediate risk, it was bone invasion, which was negative prognostic factor in both bivariate and multivariate analysis. In the high group, it was margin, DOI, PNI, histologic differentiation, and and pathological T staging. All were considered to be the risk factors. Now coming to immunotherapy. So this is a phase 1 study which has 37 patients, and out of which 29 patients are from oral cavity. The modality of treatment is immunotherapy, chemotherapy, and radiation therapy. And they were being evaluated 4 weeks post IMRT. Now, the primary endpoint of the dose-limiting toxicity was defined as the occurrence of any severe adverse events in the study, and the secondary endpoints which were analyzed were 1-year disease-free survival, Overall survival, local regional failure, distance metastasis, rate of acute and late toxicity. Now, the most common adverse effects which were seen in the study, which was due to pembrolizumab, was lymphocyte count decreased, mucositis, WBC decreased, and dysphagia. Coming to the overall survival in this, at 1 year was 81.1%, which was good. Disease-free survival was 62.3, and local regional failure was 18.7, and distance metastasis was 15.9. It is still in trial phase, and this was just phase 1 study. Now coming to another study where they've used cetuximab. This is a phase 3 trial, and patients were randomized with or without cetuximab and along with radiation therapy. IMRT was given 60 to 66 gray along with cetuximab with a loading dose of 400 milligram per meter square prior to RT, and then 250 milligram to a total of 11 doses. Total number of patients enrolled were 702, out of which 577 were eligible, with 64% having oral cancer. When we compare both the groups, the cetuximab group had a better overall survival, better disease-free survival, and failure was seen to be more in the RT group. Disease-free survival was statistically significant. When we compare the toxicity, the late toxicity was found to be more in the cetuximab group, which was 33% compared to the RT group, which was around 29%, though it was statistically not significant. Now, these are the studies which are still under trial, which is Zivanapant, which is a promising drug, and it is an antagonist of inhibitor of the apoptosis proteins. It can be used in patients who are cisplatin ineligible. The second is a trial which is cisplatin along with IMRT or without IMRT. Another trial is durvalumab with tremelimumab along with IMRT. Coming to the grades of toxicity, WHO has given it divided into 5 grades, where grade 0 is none, grade 1 is mild, where a patient has oral soreness and erythema, grade 2 is moderate, where along with oral erythema has ulcers and can eat solid foods, grade 3 is oral ulcers requiring liquid diet only, grade 4 is life-threatening with oral elimination not possible. Now, with this, I've come to the end of the seminar, and to conclude, I would like to conclude it with a multidisciplinary decision considering the major and minor risks for recurrence for post-operative adjuvant treatment is very important. Positive resection margin and ENE are clearly high-risk factors. Increased number of lymph nodes shows aggressive behavior biologically, thus multimodal approach is advocated. Cisplatin till date remains the standard of chemotherapy for adjuvant chemotherapy. Immunotherapy has an emerging role in post-operative adjuvant setting. References. Thank you.
So thank you. Again, the dictum is clear-cut. You need to give adjuvant concurrent chemo radiation. You know, the point of discussion, debate and everything is the intermediate group. Because intermediate group, you know, that comprises a different subset of patients. On the one hand, you have low volume disease, a T1, T2 with N1, what she told. So when we are telling N1, it's again from, it could be a microscopic single positive node. It could be a single positive node up to 3 centimeter in size. So you can, you know, understand the difference in prognosis between a 1 mm and a 3 centimeter node. So for T1, T2, N1, low volume disease, we are looking for de-intensifying the treatment, because radiation and chemotherapy, they have their own side effects. So just to improve on the, you know, quality of life, we are looking to de-intensify treatment in T1, T2, N1. And on the other hand, you have, you know, patient with multiple adverse factors. They'll have multiple lymph node positive, LVI is positive, PNI is positive, the margins is closed, or you have a lower, level 4 lymph node which is positive. So practically for all these patients, we do add concurrent chemotherapy to the radiation protocol. So this is what we follow. And then of course, cisplatin is the drug of choice. If the patient is not fit for cisplatin, we can take docetaxel, or if the patient is an elderly, patient can afford, can add immunotherapy.
Yes,
So any
ma'am.
questions?
Ma'am, we have a question.
Dr. Vinay, do we have any questions?
Yes, ma'am. Dr. Soumita has asked a question like, if there is a worst pattern of invasion of level 5 and it's a T1 or T2 disease, do we, without any other worst prognostic factors, do we add adjuvant?
No, WPOI and PNI, both things I take together because they are poor prognostic factors. But PNI itself, as of date, only PNI present, it's not an indication for any adjuvant treatment. But usually what we see, there is a PNI that is associated with other adverse. Either the patient will have a node positivity or an ENE, or the DOI is more. So usually PNI is associated with other adverse factors. But if for any case only PNI is positive and there are no other adverse factors, we don't give adjuvant treatment. Though PNI is a prognostic marker that shows, as you have seen in many studies, the survival, it's a poor prognostic factor, but not a predictive factor for adjuvant radiation or chemotherapy. Same with WPO. We need more studies till they become an independent factor requiring adjuvant treatment. Till date, they are poor prognostic factor, but no guidelines for giving adjuvant treatment.
Does anyone have any other?
And then for adjuvant treatment, I would like to add, there's a very good trial from Sharvani ma'am, where they are trying to actually intensify the adjuvant treatment when the patient has a combination of all the poor risk factors. That is, you have a T3, T4 with an N2, N3 and extranodal extension. So there you can actually, accelerate the radiation. Instead of giving 5 days a week, what we normally give, we can give 6 days a week. So that will add to the biological effect. And, the OCAT study, what I read in their conclusion, they had a benefit. The study showed a benefit in patients. The HR risk actually came down to 0.58 and 0.6 when the patient had all the risk factors together. So we actually need to intensify treatment in these set of patients which are really at a very high risk of distant metastasis or locoregional failure.
Yes, ma'am. The study where 5 to 6 nodes were considered.
Mm-hmm.
What do we use?
So practically what we are doing, or what I think most of the radiation oncologists, they are practicing. See, there are certain high-risk cases, like if you have a CA tongue patient, that is a very notorious disease. If the patient is young age, we do have multiple lymph nodes, none with extranodal extension, or if the contralateral nodes are positive, or if the node at level 4 is positive, we add concurrent chemotherapy to radiation in such cases. Or patient with multiple nodes and LVI and PNI, we add concurrent chemotherapy to radiation.
Most of the times, when we as surgeons we operate and we find intraoperatively that there might be extranodal extension because of the fixity or peritumoral or the tissues around the nodes. And finally, we get in the histopathology that it was there is no ENE or. But based on the clinical ground, so on the intraoperative, like a surgeon's review, can we consider like adding them to the CTRT group or something? Are there any trials based on that?
The HPR is considered to be the gold standard, but then when deciding for the patient, we take into account everything, the clinical finding, the intraop finding, the radiological finding, and then we, there are some cases which need to be decided, and that's why we have, multidisciplinary tumor boards. Yes. If clear-cut cases, there is no confusion. We have to give. But then there are some cases, which are being studied. So many things. Like Sharbani madam, she studied the other adverse risk factors, and she took only the tongue cancer patients and the GB sulcers. These two they are very common in our population. So I think we need to have our own guidelines. What we routinely observe, anyone practicing for 10 years or 15 years, they know that tongue cancers are really bad.
We have even shifted ourselves.
Yeah, we need to build up the evidence
section to modified radical negation in tongue cases because it is very notorious.
Dr. Vinay, you're not very clear. Actually, your voice is echoing.
Now, ma'am, you can hear me.
Now I can hear you.
Almost we have covered everything like PNI as an independent factor, single node positivity, multiple nodes, immunotherapy. Docetaxel is established in cisplatin ineligible patients. I think we have covered all the topics.
Yeah, we have covered almost all the topic, and I think there was a study which further classified, N1, T1, T2, and N1 disease according to size, less than 1 centimeter, 1 to 2 centimeter, 2 to 3 centimeter. And they said that yes, we can possibly avoid radiation in neck nodes with less than 1 centimeter. So maybe in future we'll have a further subclassification of N1 disease. Because yes, we are not when we are talking about all these things, we seldomly talk about the quality of life, which is very important in a patient head and neck cancer treated with adjuvant radiation or chemoradiation. And these T1, T2, N1 disease, they usually have a good survival. So we need to look into the quality of life, and if we can find something to de-intensify the treatment, will be, I think, very good for them.
Yes.
Okay, so anyone wants to comment?
I would really like to thank Dr. Richa for taking out her time on this day. Some things which I want to just add on or maybe summarize is that a lot of discussion is going on about PNI positive or the depth of invasion or other single adverse prognostic factors. So the dictum is that currently, as Madam said, that there are three groups of patients: low risk, intermediate risk, and high risk. We know what are high risk. We know what are low risk. Intermediate risk, the usual dictum as of now is that if we have more than 2 soft indicators for radiation or adjuvant treatment, we usually go for adjuvant treatment. Now, all these individual risk factors are usually soft indicators. What are these individual risk factors? Say multiple lymph node. Multiple lymph node positive, again, it's a matter of discussion because there's a protocol that many people want to add chemotherapy to adjuvant radiation. So the soft indicators may be, say, a single a PNI present or maybe depth of invasion on the higher side. So usually many people do not give radiation in these cases. But now the trend is towards treating these patients because now we have more and more evidence coming in which is showing that there are higher locoregional failure rate in these kind of patients. For that matter, there's one trial going on in TMH right now, ARREST trial, which is trying to address the need for adjuvant radiation in early T1, T2 lesions, wherein the depth of invasion is more than 5 mm, 5 to 8 mm. So I think Madam will be in a better position to comment on these things. But this clarity of thought is very important. That there's no standard guideline for these intermediate patients. Many things can be discussed in multidisciplinary tumor board, and hence a multidisciplinary tumor board is very important for these patients for deciding the treatment. There are many soft indicators. There are many confirmed indicators. There are many times we have to have a discussion with the treating surgeon regarding the kind of tumor it was. So these are very important factors. Other question which you asked, Dr. Vinay, that many times we encounter that there is frank ENE, visible ENE. And we do not get ENE on final report. So, see, obviously histopathology is the gold standard. Many times what also happens, we see that there is very soft tissue deposits present in the neck, but we do not get this as a ENE. So in the final report, so these lesions are basically grade 4 ENEs, where the ENE has gone far away from the lymph node and they are presenting as soft tissue deposits, and they can be missed on final HBR. So surgical interpretation and surgical notes are very important, that okay, grade 4 ENE was present during surgery. So this is the importance of surgical notes and multidisciplinary treatment decision making for these kind of lesions. Apart from that, there are many ongoing discussions, such as addition of chemotherapy in multiple lymph nodes positive, especially more than 6 lymph nodes, giving radiation to contralateral node or ipsilateral node in nodal positivity or ENE positivity, avoiding chemotherapy in micro ENE positivity. This is also a very important discussion. So if the ENE is less than 2 mm in a single lymph node, then many studies are saying that you can avoid giving chemotherapy, though the evidence is really very low, and current dictum is to give chemotherapy in this kind of situation. Then again, the other thing which Madam said, in single lymph node positivity, many times we look at the size of the micrometastasis. If it is less than 2 mm, then we can, many people very strongly recommend that we can avoid giving radiotherapy if the size of nodal metastasis is less than 2 mm. More than 2 mm, there is contention that we should give or we should not give. But all these are still a part of discussion. The standard treatment line: low risk, no need; high risk, go for it; intermediate risk, MDT.
Yes, rightly said, Dr. Ravi. And then I would also like to add upon the PNI. You know, PNI is not just a single entity. It could be a focal PNI, it could be a gross PNI, or it could be a perineural tumor spread. The PNI could be involving a minor nerve, it could be involving a major nerve. So the prognosis and the things change. Whenever we are giving radiation for a PNI positive, especially, you know, in salivary gland tumors and all those tumors. So if there is, the disease is gross PNI, we trace the cranial nerve up to the base of skull. Our target volume changes, our dose changes. But if it's a focal PNI, okay, it's fine enough. The local nerve area is taken. So what type of PNI we have, that is also very important.
True. Point well taken, madam. Absolutely.
And similarly with LVI also, you know, like in endometrium, now we have a different classification now for focal and extensive. There are different terms. They use a focal LVSI, an extensive LVSI. So something 1 mm, 2 mm, you can pick it up with, you know, pathology. That is a different thing, and something gross, which you can see with, you know, naked eye. So that is, I think, definitely that is more aggressive and needs to be taken up more aggressively.
True. So this is actually a very important point, because many times we get pathology reporting as PNI positive.
Yeah.
They can be just intratumoral micro PNI positive.
Involving a minor nerve.
Minor. So these are not actually that poor a prognostic factor as having a major nerve being involved.
Because facial nerve is being involved in CA time. So that is a very bad. We need to trace up to the base of skull, the origin of skull, yeah. So that changes our target volume with IMRT now. We need to be very precise with our target volume, because now we can actually go up to base of skull, which was not possible with those cobalt and, you know, 3D CRTs.
True. And this is a very important significant surgery also, because during our surgery, madam, many times we get the frozen report that disease is, the PNI is positive on frozen section. So in those cases, we go back to the pathologist and we ask that where is the PNI positive exactly? Is it on the proximal of the tumor or the end of the tumor? Because if it is anteriorly, suppose in a buccal mucosa, if it is anteriorly, then we know that we have, where do we have to take the margins? We have to move more anterior, more posterior. Posterior, we can go up to the skull base. Foramen ovale, we can remove the ITF. So these are very important in these cases. True.
Anyone want to add something?
Wanted to discuss with Shikha that, and I actually wanted to highlight, because these are important consideration, that why is 70 years considered a relative contraindication? Does she know about it? Why 70? Why the figure of 70? Or maybe why CTRT post NSCT? What does it mean?
CTRT post NSCT is because when we give NSCT in head and neck, there is not a concentric shrinkage of the tumor. The tumor foci might be left behind.
Perfect.
So in that case,
perfectly said. So basically, technically, what means that when we are giving NSCT and we are operating the margin, even though our margins are clear, so it is called as increasing the sterility of the margin. Even though histopathologically our margins may be clear, we consider the disease to be technically or grossly margin positive because the tumor does not shrink in a radial fashion. Okay, it shrinks patches. So even if we are taking a margin just at the previous tumor border, there is a possibility that there could be some microfocus of disease left over there. Hence, NACT cases are considered to be technically margin positive even after even if we have clear margins. So all NACT cases go for chemotherapy. Clear?
Yes, sir.
So one doubt, sir. In NACT, so already we are using only half cycles. Now most of the time we are not using all full cycle. So adjuvant, we have to give overall to complete our therapy.
What is half cycle and what is full cycle?
In all other organs is like they are fixed. We have to give 8 cycles or 4 cycles. Like that, so we are giving 2 cycles before and 2 cycles after surgery.
So no, it is not like that, Dr. Samita. So NACT, the concept is that we give neoadjuvant chemotherapy. Okay, there is a maximum limit of neoadjuvant cycles that you can give. It is considered to be 5. Okay, the reason being that beyond 5 cycles, there is no added benefit either in terms of overall survival or in terms of locoregional control if we are planning some locally ablative therapy. Okay. Usual response assessment is to be done after 2 cycles. If you are getting a response after 2 cycles, you can consider, okay, this patient may go for, we can continue giving this chemotherapy to this patient. If we do not get a good response after 2 cycles, so the response can be divided as complete response, partial response, stable disease, and progressive disease. Complete response means 100% resolution of disease on imaging and clinical examination. Okay.
Yes, sir.
Then partial response means 20% less. 30%. More than 30% reduction, but not complete resolution. Stable disease is less than 30% reduction or less than 20% increment. That is stable disease, and if there is more than 20% increment, it is called as progressive disease. So there can be progression of disease also. So we will not keep on giving chemotherapy to the patients who have a progression of disease. Getting the point? So there is no ऐसा कि minimum इतना cycles आपको देना है for completion of neoadjuvant chemotherapy. At least what I know of. I think Richa madam.
Yes, Dr. Samita, I think you are confused with the rectal cancer where we give a TNT 6 to 8 cycles.
No,
so
ma'am, in breast also we do the same. Na? That's why I was asking.
Breast cancer patient will anyway require chemotherapy. It's not the question of downstaging. They will anyway require chemotherapy because breast is considered to be a systemic thing. Like if we have a cervical cancer patient with paraortic nodes, bulky paraortic, we want to downstage that patient before giving radical chemoradiation. We do give 3 to 4 cycles.
So this number of cycles is not fixed, na ma'am? ये मैं पूछ रही हूँ.
No, it's not fixed. But if we are using chemotherapy only for downstaging the stage of the patient so that we can do a proper surgery with good margin or give radical chemoradiation, if the paraortic shrink, we can save the kidneys. So that is only for 3 to 4 cycles. But things are different with rectum and breast. They will receive 6 to 8 cycles of chemotherapy, either in the neoadjuvant or in the adjuvant setting.
Okay, ma'am.
Thank you. Neoadjuvant is basically used to downstage the tumor so that it can be surgically resectable.
Actually, sir,
Yes.
perioperative
All organs
therapy
it is
like
fine.
concept came into place in many organs. So, in that setting also we are giving 4 cycles before, then we are operating, and 4 cycle after that. तो head and neck I was not aware कि ऐसा कुछ रहता है, but this point I got it.
No, but for all like ovarian cancer. So ovarian cancer is anyway they will require systemic. They need at least 6 to 8 cycles of chemotherapy. So if you are giving 4 before, you need to complete that because they are considered to be a systemic disease having very high propensity of distant metastasis. They're different too, but head and neck is a local disease. Cervical cancer, it's a loco-regional disease. The spread, the pattern of spread, what we see, and the patterns of failure, what we see, it's going to fail in the local area. Either you're going to have a recurrence at the cervix, it will recurrence in the bladder, the rectum, and RVF, BVF, or they will recur in the pelvic or the parotid nodes. I mean, they do recur with, lung meds and systemic meds, but that, that propensity is quite less. So they are basically considered to be a loco-regional disease. I think that is the same concept with head and neck cancer. So we try to intensify the loco-regional treatment. We are not much worried about the systemic spread.
Thank you, ma'am.
Sir, for the 70-year, I think it is because 70 years, after 70 years, there is no much benefit of chemotherapy. As there was a study which was conducted in 2009, there was a meta-analysis which showed that there was not much of benefit of chemotherapy in patients older than 70 years. That is one. And second thing, they will present with more comorbidities. So I think these two are the reasons.
Yes, I think, yes, you're right. So these are the important reasons because it is assumed. So people try to find out that why 70 years is not responding to chemotherapy. So it is because most of them were presenting with many comorbidities, and the overall benefit added by chemotherapy did not surpass the overall survival which a 70-year person has. So benefit
Yes.
And then now you have immunotherapy for these subset of patients, especially for the elderly patients. Now immunotherapy they are better tolerated.
True.
Take apart the cost factor. You started with the cetuximab with the trial Bonner et al. And now we have, the HRG and NRG trials. Now pembrolizumab, nivolumab, and now durvalumab is also coming. And another thing I would like to add now, if you want to intensify the treatment, the patient is not fit for concurrent chemotherapy. I mean, concurrent cisplatin, patient is not affording immunotherapy. You can go for an accelerated radiation. By accelerated radiation, you can give either 6 days a week, that is treating the patient on Saturdays, or you can treat the patient twice daily in a hyperfractionated dose. So they are biologically more effective than the conventional 5 days a week fraction. So that is another thing. If you go stepwise, most effective concurrent chemoradiation, biologically effectiveness I'm talking about. Most effective is concurrent chemoradiation. Then is the altered fractionation schedule in which we have, treating 6 accelerated radiation or hyperfractionated radiation, and then comes only conventional radiation.
Yes.
So Dr. Vinay, I think we are done.
Yes, ma'am. Yes, ma'am. And thank you, ma'am, for facing this session. And
okay, thank you so much
for participation.
Okay, thank